Good evening, all. This is Dr. Santwana Vernekar, and on behalf of CAHO, the Diagnostic Division, we welcome you all to the Team 13, that is the Pre-Examination Variables in the Field of Diagnostics and Management, Part 2. Dear participants, we have with us today Dr. Rajesh Bendre, who is a MD in Pathology, DNB, and DPB. Currently, he's the Chief Pathologist and Lab Head at Newberg AG Diagnostics Private Limited, Mumbai. In fact, Sir has a vast experience in the field of laboratory medicine, with his technical work experience of more than 22 years, especially his in the clinical chemistry and hematopathology and molecular pathology. As far as Sir's academic teaching experience is taken into consideration, he's a MBBS and an MD DNB path. He's been teaching the postgraduate students for more than 10 years. The 5 international publications and participated through posters and oral presentations in many of the international and the national conferences. Sir is an accomplished NABL and a CAP assessor as per the ISO 15189-2012 standards. His special interest is in autoimmunity, in flow cytometry, in hormonal and drug assays by HPLCs, LCMS technologies. Sir is trained in the management of component blood bank, in apheresis services and laboratory management through IIM Kolkata and IIM Indore. He's acquired skills in development and implementation of laboratory information systems, that is LIMS. On a personal level, I would say that I've been blessed to work with Dr. Rajesh Bendre, a very humble, and though he's so knowledgeable, but he's a very down-to-earth person. And I have learned a lot of leadership skills with him during my brief stint. So welcome to you, Dr. Rajesh Bendre, and let's take the session ahead.
So very good afternoon, everyone. And at the outset, I'd like to thank CAHO and Dr. Aparna for giving me this opportunity to share some of my thoughts today. So with that brief introduction, and thanks Dr. Santwana for that quick, nice introduction for me.
Yeah.
So let me begin this topic, which is of pre-analytical quality indicators in laboratories. Now, this is a topic which I must say is something which is, I should admit rather, is something which is a difficult topic, and something which we all have learned through our bitter experiences. And there is very little literature on this particular topic. So I would do my best, and I hope that it is up to your satisfaction as to whatever I am going to share now. So let's begin with some basic concepts. When we talk about laboratory quality, and if we look at the definitions of a lab quality, there are various definitions given in the literature. But I suppose these are few points which I could pull out, which I think relates the best in terms of what we would define as a quality. So lab quality is nothing else but totality of the features and characteristics of the product or the service. In our case, it is our results and service, which bear on its the ability to satisfy stated or implied needs. Or the other way of looking at would be the reliability of our results in a given condition. And still other way of looking at would be consistent performance, satisfying the needs or the expectations of the client. In our case, the client is basically the patient. So consistency and being right, giving right results, not only the first time, but every time is what we want as lab quality. And in order to do that, we all are striving hard, basically, to achieve an error-proof report and generate a confidence of the clinicians and the patients in the results that we are giving out. So we want to build a credibility of our lab through our quality results. But unfortunately, all this lab quality and a lot of efforts which go into that, unfortunately, it is often always invisible. As the results correlate clinically, there is never something which a clinician would really come back, or rarely I would remember an instance where a clinician has called you back and told that, yes, your lab results correlated very well. I could very few examples that I could relate from my experience. But on the other side, if the results are non-correlating or it is just off the expectation, it is considered, which is something which is very bad, is considered as a laboratory error, and it reflects badly on the lab quality, and it is something which no one will ignore, or it is impossible to ignore at all. If the lab quality is bad, we all know there is always serious implications in terms of legal actions as well. So we all have to be on our toes and keep on continuing this journey on lab quality and keep on generating consistent, accurate reports for all our patients. So that is what I want to set a preface to. When we talk about laboratory errors, we all know this slide, which must have been shown periodically on most of the conferences or most of our presentations. And we all know that the errors we often divide as pre-analytical, analytical, and post-analytical. In fact, the pre-analytical one, if we have to further drill down, we can further subdivide it as pre-analytical and pre-analytical. But suffices to say that it contributes to almost 68 to 70% of our laboratory errors. So this is definitely an area of focus and should be the area of focus for all of us. In terms of the pre-analytical errors and impact on the patient results or the patient harm that they can do, here are some of the examples which are quoted. Like if we have missed a hemolytic sample and reported on a hemolytic sample, it's a falsely, say for example, potassium, where it is the most severe impact that you would have for on a hemolytic sample and reporting a high potassium value is one example. Reporting of coagulation tests when it is an improper collection, especially underfilled tubes. All these are very serious pre-analytical errors which have got a direct impact on the patient results and hence patient harm. And we need to have our own review of our pre-analytical process. So when we talk about pre-analytical process, here is the catch and here is the difference. When we look at various labs which are there, you could be working in an environment which is a hospital-based lab. You could be working in a standalone laboratory. You could be working in a reference laboratory. Now, each of these settings, the pre-analytical process when we talk about is different. And hence, one unique example or one unique rule or an SOP cannot be just copy-pasted to all of us, because it is different for all of us. The pre-analytical process is different for all of us. And I suppose the most complex amongst them is in a setting of a hospital lab and in a setting of a reference lab. Because in these two areas, the person who is collecting the samples is often totally different and is totally not under your control. In a hospital setup, you all know that many a times that it could be a nursing staff, or it could be a doctor himself, and of course it could be our team members, that is our phlebotomist. So it could be either of them who could have been collecting the sample. So it means that there is a lot of variability from person to person, the way the process as a blood collection process or a phlebotomy process would have been done. So getting standardization here across all the personnel, which is across different departments or disciplines, is something which is challenging task in its own. Similarly, in a reference lab, you have a lot of samples which come to you as lab-to-lab reference, and there the sample is collected by that referring lab. Now, how that referring lab has really collected the sample, it is totally something which is known to that lab only, and a reference lab is totally unaware of it. The only way that a reference lab can give guidelines to that referring lab that this is what is recommended, this is what is required, and they are supposed to follow those instructions. But what I'm trying to emphasize here is, and as you can see in this slide, each and every step right from test order to sample collection to transport of sample until that the sample reaches the lab and we accept the samples, each of them will contribute in some form of pre-analytical errors, and they are a part of our pre-analytical process. One has to really drill down, really study this entire process of the pre-analytical way the system is working in your setup. And that will give you hints to what are the quality indicators, which is what I will be talking in the next subsequent slides. But the preface to that, or the clues that will give you or which will come out from, is your review, a thorough review of your own pre-analytical processes. That is what is very, very important. And unless that is done, the quality indicators which you would set for your lab will not really help you and will not really contribute in a continual improvement for your lab. So that's the point which I am trying to make here from this slide. To further make it more elaborative, I would like to draw everyone's attention on certain areas in the pre-analytical process which I would definitely say are neglected, or if someone wants to put it in a milder way, maybe due to oversight are not looked into that great importance. So here are some of the points which I have written down. The phlebotomist which is doing the blood collection, the phlebotomist needs to follow certain protocol, and the protocol of, say, hand hygiene practices, protocol of the tourniquet which the phlebotomists use. Now, if we look at the various collection material that we have, there are two materials which are not really disposable as such, and those are the tourniquet and the needle holder. And that is where our focus should be, that how do we ensure that though the tourniquet or the needle holder is reused from patient to patient, how do we ensure that it is still clean, it is still sanitized, and we are not introducing any kind of infection to the patient. In fact, there have been various studies published already where these practices, if not followed, have contributed to the transmission of infection of Staph aureus and MRSA, especially in a hospital setting. So hence it is very, very important and very, very necessary that the phlebotomist has been trained properly and is following certain recommended protocols in terms of your collection, blood collection procedure or phlebotomy procedure. So this is one area where there is always a scope for improvement. Another important point which I want to draw your attention is post-phlebotomy care. There are hardly any instances where we really give any instructions to the patient as to what care the patient should take post-phlebotomy. Simple instructions like do not use this hand for at least 24 hours, especially in an elderly patient, which can contribute, to formation of post-phlebotomy complications like a hematoma, for example. So simple things, once you have collected the sample, we hardly check that the patient has really pressed the cotton after the phlebotomy for good time. I often see that the phlebotomist misses in checking before applying the bandage that the blood has really stopped. So all these simple points needs to be looked into so that these kind of complications can be averted. Since phlebotomy is a person-dependent technique, all these minor points and training is a very, very crucial point in terms of controlling and putting some standardization in pre-analytical process. Another important point which I want you to focus on is the other part is adoption of newer technologies. If we look at various labs across the country, I'm sure there are still labs which are still sort of not very comfortable in using vacutainers due to whatever their constraints or reasons that they have. But adoption to new technology, one is usage of vacutainers, which ensures that the right amount of sample is collected in the containers. Usage of newer gadgets that we have in identifying or facilitating the phlebotomist in identifying the vein. Like we have a lot of these laser gadgets which will help us in identifying the vein and avoid a possibility of a double prick. It will facilitate the phlebotomist to select the vein correctly So adoption of all these newer technologies is going to help us. So we need to be open to have adopting these newer technologies in this particular area of phlebotomy collection. Similarly, we need to ensure the safeguard of the phlebotomist. We need to have some process by which needle stick injuries are avoided to the phlebotomist. And one way is to use eclipse needles where it ensures that the needle stick injury is not there. Similarly, I have shown you the diagram which is of your butterfly needle whenever the vein is very thin, or in elderly patients where the veins are slippery. So you need to use these things, and this kind of a training should be given to the phlebotomist. The another one which I want to draw your attention is the transfer devices. There are a lot of transfer devices available today, which again we need to adopt and use, especially when in a hospital setup where we have to often collect samples from an indwelling IV lines. So there has to be a protocol or a process how we would collect a sample from an indwelling catheter or an indwelling IV line, and these transfer devices will play an important role there. This will definitely ensure that there is no hemolysis which would occur. Routinely, what the nursing staff does is they would collect it in the syringe and then they would push it into the vacutainer. And this definitely causes a physical, harm to the cells. And this is going to cause a hemolytic sample by the time that it reaches the lab. And it adds on to our rejection rates of hemolytic samples. So all these newer technologies that we have, we need to review them, and in my experience, adopting them definitely helps us in streamlining our own blood collection process. So coming to a very important point is training. I just said 2-3 times about training. So just briefly talking about training and as to what we need to really do. And I would like to share this based on my own experiences in my current organization as well as from my previous organizations, that how and what we did. So phlebotomy, as we all know, is a person-dependent skill. And the only way to ensure that everyone is following the same protocol is training and repeated periodic trainings. So that is the only way we can ensure that everyone is following the same protocol. There should be a protocol in terms of a new phlebotomist who is joining us. How are we going to have an induction for that particular phlebotomist, and what all we will train that phlebotomist. And similarly, the existing phlebotomists that we have, they also need to continually get trained, and we need to update them on new technologies, as I told you, or whatever new tests that we would have added as a part of our directory of services, and the relevant information to that test in terms of the sample type requirement or in terms of the patient preconditions which would be required for that test. So training is a crucial part, again, I'm emphasizing. And as per our any standards and as per any good practices also, only training is not enough. We have to get a confirmation that whatever training we have imparted, the phlebotomist has understood it. And the only way we can know this as a confirmation would be through a competency assessment evaluation. Now, the competency assessment evaluation also can be done through various modes, and there are various models by which we can do this. So I would like to give few examples as to how in the area of pre-analyticals or in the area of phlebotomy as to what models will work, and it has worked in my experience. So one way is to develop a checklist. Say, for example, you have written in your SOP that you want your phlebotomist to follow, say, about 14 steps before a person would do a blood collection. So these 14 steps which are a part of your SOP, you can make a simple checklist out of it. And it is your quality manager or your lab manager uses this checklist as a direct observation, where 2 or 3 collections randomly of that phlebotomist are done under these lab manager or quality manager supervision, where he uses this checklist and grades that phlebotomist. And if there is a deficiency observed there, that phlebotomist undergoes a retraining again. So this is one way to ensure that they are really following your SOP. Another way is indirect ways would be the TRF or the test requisition form that the phlebotomist would fill Are they filling and capturing all the required information as you would like to want them to capture? I'll give you an example. For example, if it is a maternal screening blood sample to be collected, you need to take all information about the patient's weight, date of birth, the latest sonography report, because of which we cannot, otherwise it will get stuck and the report would not be generated. So monitoring of TRFs and ensuring that they are capturing as per the test requisition, taking feedbacks from the patient to find out whether there are any post-phlebotomy complications that are happening, and creating some problem-solving skills to assess their knowledge for the tests and for the phlebotomy. So the next slide, I'm showing some of the examples which I have used in my lab. So this is one simple example of a phlebotomy competency assessment checklist, which I mentioned to you, which you need to develop as per your process in the lab and use it for a competency assessment. The other example I have shown on the left side is a simple MCQ, but that MCQ, what I want is, many times we see is that simple one-liner theoretical MCQs are created by most of the labs. But I think that's not really going to help us. What we need to do is create some kind of practical examples. Like this is one example I'm giving you, where a patient has given a 24-hour urine sample and the patient has collected it himself in his own container at house. And the patient is saying that he has collected all urine sample, but the first morning urine sample he has not collected. So this way we can send and check the knowledge of that person, which is from a case which is of practical day-to-day utility. And this will give us the right information and make us understand the need for training for that particular phlebotomist or that particular individual. So these are some examples which I'm trying to give you how we can make it better or how we can improve it. Having said about the blood collection and about the accession part of it, when we talk about pre-analytical, one should also understand that there is another pre-analytical area, which is post-accession, but before the sample goes for actual processing. So this also, according to me, is pre-analytical. And here are some of the examples. For coagulation, we need to ensure that before the PT, PTT or any other coagulation test is run in the instrument, the platelet poor plasma is generated. And for that, we need to have the recommended speed for the centrifuge and the SOP, which usually is there as a part of our test SOP. But this actually is a part of a pre-analytical process. The daily background checks for cell counters for a CBC. In urine chemistries, checking the urinary pH before the sample goes for any urinary chemistry testing parameter. In microbiology, serology, especially ELISAs, most of the ELISAs, there is a pre-dilution step of the sample before it has to go for actual ELISA testing. So these are some of the examples which also comes under the purview of pre-analytical, and they also need to be reviewed and need to be monitored when we talk about pre-analytical as a process. So this is a background that I wanted to first give and create when we talk about a pre-analytical process. Now let us talk about how do we monitor these pre-analytical processes which we have just now discussed. And one of the best ways to monitor these pre-analytical processes would be to set our own lab-defined quality indicators. So when we talk about quality indicators now, which is our main core of our topic, whatever I have said just now is what we need to use in order to select our appropriate quality indicator in the pre-analytical phase for our lab. And here are some of the guidelines which we would look at, generically speaking, when we are selecting a quality indicator. Now, these guidelines are not only specific for pre-analyticals, but they also apply for the analytical and the post-analytical areas. The same guidelines applies there as well. So we always say that a quality indicator should be something which is measurable or quantifiable. And unless it is measurable or quantifiable, that's the first requirement. So we need to first find out when we are selecting a particular indicator, do we have the required either IT-enabled provision or a manual way of recording the data and then quantifying it? So this again is very, very important and crucial, that it should be quantifiable. Having it being quantified is not enough. We should be able to have a review mechanism to that, and should be able to troubleshoot and identify what corrective actions we can take, so that this quantified number, when you start monitoring month on month, that you would be able to see an improvement in that particular indicator. So in nutshell, we can sometimes call it as a SMART indicator, which is an acronym to say it as it is specific, it is measurable, it is attainable, and action oriented, relevant, and time bound. Time bound again is very, very important. So what it means is that once you have started reviewing and monitoring, you will set some kind of a goal or a benchmark to it. And once you have achieved that benchmark, then you have done your job. Then you again have to review and decide whether you still want to continue to monitor this parameter, or you want to change your strategy or your quality indicators. So this is in nutshell, which I would like to say, that when you're setting or selecting a quality indicator, all these points we need to keep in mind. At the same time, we should not go too overboard and take a huge number of quality indicators where we ourselves are bogged down with data, and when we really don't know what to do about the data. So select something which is useful. Select something which are your problem areas in your pre-analytical process, where you taking actions will benefit your lab and finally benefit the patient. Unfortunately, there is no formal list of quality indicators in pre-analytical area that we can really talk about as a standardized list, but there is definitely an attempt, and an excellent attempt towards that. And there is a very good publication from IFCCC, and IFCCC has established a working group for laboratory errors and patient safety, and has published a document on 2017 talking about the recommended or suggested quality indicators for laboratory. Now, this paper talks about quality indicators across the lab. And if you go through this paper, they would have enumerated almost more than 60 plus quality indicators in this paper. But that doesn't mean that every lab will start doing 60 of them. We have to select appropriate ones which are applicable to us. So today, since I'm talking about pre-analytical, and I've shown you a chart from that publication only, which is showing a pre-analytical quality indicators as recommended, suggested ones. And the list, as you see, is total 16, which they have recommended. And if you look at it, the approach that they have used is they have targeted one area, which is appropriateness of the test request. Second area is the examination request and identification of the patient, and samples, related to samples. So they have divided it as an approach. These are the focus areas in the pre-analytical zone, and in that they have tried to categorize what are the possible quality indicators that you can use for monitoring. So using this, I'm going to show you now what are the quality indicators that we have been using, or I have been using in my previous 2-3 organizations that I had worked. So these are the ones which I have been using, and I think they have helped me in streamlining the pre-analytical processes in the laboratory. So you can see that I have chosen the 3 areas in the pre-analytical process as the phlebotomy as such, sample transport, and sample accession. So these are my focus areas in the pre-analytical zone, and under them I have enlisted what all things I want to take up as a quality indicator. Using the earlier reference document, which I just now told you, also talks about certain benchmarks, which I have put it as optimal, while what I have put is based on the lab, our own data as to what is my baseline and what is that I can achieve in a realistic way. So though for misidentification errors, the benchmark is 0.08, which is almost like 0, I have put it as less than 0.5% as my beginning start, as my lab defined benchmark. Of course, my goal and my dream is to achieve 0.08. But I can begin my journey to achieving that dream through my own data as a benchmark as to achieve first is less than 0.5%, and then I can still aim higher to achieve 0.08%. So that is the approach that one needs to put when we are setting up the quality indicators for a lab. I'm going to elaborate some of them in the subsequent slides where this thing will be more clearer now. There are two things which require IT help, or it has to be IT enabled. Like when I write here at sample transport or logistic turnaround time, and when I write here at sample accession turnaround time. Now this, unless the timestamps are captured at the time of sample collection by a logistic person and the timestamp of sample receipt, and is not captured in the system, we won't be able to calculate the turnaround time. So capturing the timestamps at that appropriate sample wise, that too, and patient wise, that too, requires some help from IT, either as a part of your LIMS, or it may be a separate utility which is acting on top of your LIMS. And last but not the least, you begin the journey by doing this as a manual activity, and over a period of time, take help from IT to automate it. So as I said, I'm going to elaborate this further. So let me take this example and show you my own data with an example of registration edits. So the registration edits, we have put as a desirable benchmark to be less than 5% and minimum benchmark to be less than 10%. Now, why do I put this as a benchmark for this particular parameter? Because you can see my own data from August 21 till July 22. What are the registrations made, how many edits have been made, and what is the percentage of edits. So if this is my data where I'm seeing an average which is coming out to be 10%. So first, let me put a benchmark of less than 10%. Once I achieve less than 10%, then I should work still harder to make it less than 5%. So that's what I'm trying to say again, but now giving you an actual real example. The same month-on-month parameter, one can put it in an Excel format and create such graphs. The graphs helps us in looking at it in a bird's eye view, and it helps us in identifying any trend or a sudden increase in that particular parameter when you compare it versus to the last month. So when you do that, it gives you a bird's eye view where you want to know that you can drill down further and try and investigate as to what are the reasons that why there is a sudden shoot up in the registration edits this month. And all these registration edits, mind you, what I'm talking about are pre-report dispatch. Okay, so this is not after report being dispatched. This is within the accession department that they only have identified the changes, which would be in terms of demography, which would be in terms of test selection, which may be a mismatch between the TRF, what is written versus what they have registered in the LIMS. So in your accession, we have put in a place of double cross check. So it is a concept like a maker and a checker. So person who is doing the registration will not do the cross checking. The cross checking will be done by another person with the TRF. So one person will do the registration, other person will do the checking part of it. So when we do that, such kind of errors will surface out. And this will also tell us the need for which is the person who requires the training. So the bottom graph you can see is we are also analyzing month on month, which is the person who has done the registration and it required edit of registrations. So by that, I understand that, like for example, in the month of December, you can see person S. You can see person S had the maximum number of edits. So I had to focus on this person S to give training to that person and understand what are the challenges what are the problems that that person is facing that these errors are happening. So unless we do this kind of a deeper analysis, we will not be able to understand what are the issues, why edits are happening. So this is one example I'm trying to give you and how it has helped me. So the overall in the entire year, you can see my highest was 15.6%, but now I'm coming down to 9, 8, and now I'm coming to average 10. So the journey is still on, the work is still in progress, and I have to still achieve my desirable percentage of less than 5%. So I was just saying that out of these points which I have identified as reasons in my lab, I would like to further elaborate on this point number 6, which is wrong test selection. And there was a lot of learning here for myself as well. And this is something which I want to share with all of you. So here, when we drill down as to why wrong tests are selected by the accession person, we understood that there is an understanding gap. And I realized that when I started looking at the TRFs and the test requisitions, there are so many tests that we have as prescriptions coming to us, which are similar in sound and it looks. So that is what creates the confusion for an accession person. So we decided to create a list that which are the tests which are look alike and sound alike, and they can refer to this test so that the confusion will not occur. And they can go ahead and select the correct test, what is written. Similarly, there are tests which have got similar names. Like you can see an example of antimicrosomal antibody thyroid is same as our anti-TPO, or P-ANCA is same as MPO, and so on. DHEA and DHSO4, they are not same tests, they are different tests. So this is a way we thought proactively giving them this information and making it available to them for them to refer. And I also told them month on month, as you come across such tests where you have got confused, keep on updating this list. So over a period of time, you get a ready reckoner for them to refer. And this would keep on as a continuous activity for them to refer, and so that the errors will not happen. I think the corollary of this came from my earlier organization in a hospital where I was working, where in NABH, we have a requirement in pharmacy for look-alike and look-alike and sound-alike drugs, and a list of LASA drugs. So I think the corollary came from there, actually. So that why cannot I apply that principle in laboratory? Because that applies and that exists even for us. And errors happen in wrong test selection because of the similarity of the names or because of the synonymous names. So this is a way, was one of the newer things which I implemented in this lab and which is helping us in reducing the errors in test selection. Similarly, I'm trying to elaborate now on all those points which I showed you earlier in a very brief way. Because of the time limitation that I have, I cannot elaborate on each and every point, but this is just a snapshot that I'm trying to give you, where how we try to improve upon the quality indicators in the pre-analytical area, which we decided to choose, and how we have tried to monitor them. Periodic training and competency assessment is one of the very, very important part which helps in improving the various quality indicators, which I emphasized earlier, which I am emphasizing again. Another important point which has helped us in a long way is a TRF, the test requisition form. So many a times, again in test selection, and in order to improve the test selection, in order to improve the way a lab would send a sample to us, sometimes the handwriting of that lab, the way they have written, is not readable. So what we also decided, we designed our own TRF, where most commonly ordered tests along with our test code is directly printed there. So it becomes easier for the referring lab just to tick there, and it becomes easier for my accession team to also do the correct test selection. So that is another point which we implemented and which has helped us. So these are some of my practical examples and practical ways that we have tried to implement as a process in various quality indicators that we had chosen. So having explained as of now on the concept of pre-analytical quality indicators, so now let's talk about quality assurance in the pre-analytical area. So I want to again apply concepts of analytical QC in the pre-analytical area. We talk about IQC and we talk about EQUAS in our analytical area. Can I apply the same principles in the pre-analytical zone? And according to me, the answer to that is yes. I feel that what we are doing as our monitoring of quality indicators with targets or benchmarks which we have decided which are realistic and which would be achievable is actually the IQC of pre-analytical zone. Periodic trainings and competency assessment is another very, very important pillar, second pillar. And third, but not the least, is an internal audits of the accession area. These three become, I think, the IQC for pre-analytical zone. Similarly, external audits conducted through vendors or third party. Many a times, in fact, nowadays, most of our vendors who supply us our blood collection material do offer this as a value-added service where they can come and review with their own checklist as to the process what we are following, and then come back to us and discuss with us the gaps, what they identified. And that will help us as a third party review and a third party opinion coming to us, which will help us like an EQUAS. Similarly, patient surveys on, especially on phlebotomy services and or patient feedbacks taken at the same time. Best would be that feedbacks are captured after every blood collection. That's the idealistic way that we can have. But if I know there are a lot of practical limitations to that. And again, you will require some of the IT help, and it has to be IT enabled to make it 100% as all patient feedback being captured. But we should aim for that. But that again is a very unbiased way that we get feedbacks from patients as to what our phlebotomists are doing, how is the experience that they are getting about the phlebotomy. So I think we can apply the concept of IQC and EQUAS in this way also to the pre-analytical zone. This is purely my thought and my experience with the way I had tried to approach it. In fact, I would love to have some inputs and feedbacks from the other seniors and my co-panelists as well on this. So this is just my thought that I felt that I should share. So having discussed all these things, that's my concluding slide. So human role in phlebotomy is something which we cannot replace. And unfortunately, it is this human intervention which makes the pre-analytical area extremely challenging and extremely unrealistic. However, if we set good quality indicators after a thorough review of our own pre-analytical process with realistic benchmarks to it, I think it goes a long way in improving our quality services and overall patient outcomes. That's what I basically wanted to share. And I conclude by just wishing everyone the best of luck for pursuing and continuing the journey in this pre-analytical QC. And I hope and I wish that for all of us, this dream for pre-analytical QC would someday become a reality. So thank you very much for a patient listening. And I'm happy to have questions or any discussion further.
Thank you, sir, for a wonderful session. And in fact, some takeaway points which I have also learned today, and definitely this is going to make a difference. The first one that I could see was, of course, on LASA and the synonymous test. In fact, as hospital consultants, we have always been discussing about LASA for medication. And today it was an eye-opener for me that we can always think about LASA and the synonymous test for the laboratories as well, because many a times there are a lot of confusion and a lot of registration errors do take place because of it, sir. So this definitely was something that all of us are taking it as a takeaway home today. And of course, all the quality indicators that you have discussed about, and also how we actually need to capture the data, whether it is a hospital setup or it's a standalone setup. It does make a difference. And once the pre-analytical or the pre-analytical errors are taken care of, I think so the system ahead becomes much smoother, and it helps with reducing the repeats or the reruns or the retests, and each and every organization can have their quality improved with taking care of this 50 to 70% of the errors at the initial phase. With this, sir, there is one question from one of our panelists as well, and I would just like to put it up at that Dr. Ananya asked that every audit, NABL proposes to add on more quality indicators to the existing list. How do we deal with that?
So I think the very fact that the auditor has pointed that more things to be added, I suppose you need to go back and review what you have selected or chosen, because an auditor will, I being an assessor also, and I'm sure Dr. Bhargava madam or even Aparna would agree with me that we also try to be very practical and reasonable about everything today, as we have also learned and grown as assessors. So I mean, when initially NABL started, probably we also were in the learning process. And I would say there was a lot of immaturity that even we had. But in today's times, I think most of us have understood, because we all know that today, if I am going into some lab as an assessor, tomorrow it is I am on the next side of the table. So I do understand the practical realities. So what I'm trying to say here is that try and take the observations made by the assessor positively, because I feel that if an assessor is pointing like this, means they are indirectly telling you that probably what you have chosen is not really appropriate to the setting what the assessor has seen in your lab. And the best would be that if you think that what the assessor is, you can upfront discuss these things in a scientific way to the assessor and try and make the assessor make you understand as to what is the point. So I don't think that it's a general thing that every assessor would like to make you do this. In fact, I try to make that point very clear that if you have achieved a benchmark of a quality indicator, in fact, it is the other way around. You should be reviewing and deciding whether you want to continue it or not. And you should be selecting some other area which is probably a problem for you, or which you think that is a bottleneck for you in the pre-analytical process, and choose that, so that when you start monitoring, something will come out in terms of your review as to what you need to really do, and that is what will help you. I hope I answer that question, because
yeah, I think I completely agree. In fact, when I remember when we used to be on the other side of the table getting assessed, every time the first few audits were like this. Okay, let us take the NCs. I remember those days. But later on, as we understood and we became assessors, we understood the other side of getting assessed. And if you can really sit across and understand from the perspective of the assessor, as Dr. Rajesh said, it would be a win-win, because you just don't take the NC and close it. That's not the, it's a voluntary thing till now, at least in our country. So I think that's a wonderful thing what Rajesh has told, and I think all of us experience it. Only thing is we are not vocal about it. So people, I have seen big organizations saying acha hai, NC hai, close kar do, but then next audit what will you do? Is it possible? So if you sit across and explain and discuss with the assessor, I think most of us are open to that. So that's a very valuable input. I think Santwana, Dr. Dipti has raised a hand.
Yes, Dr. Deepthi, please go ahead.
Good afternoon, sir. It was a very nice presentation. I am Dr. Deepthi Madhu. I am the Chief Quality Officer and Infection Control Officer at Caritas Hospital, a microbiologist by background. So it was a very eye-opening presentation. Just like ma'am said earlier, the look-alike and sound-alike tests are a real eye-opener. I can see that you've put in a lot of work to bring about that list. And if I may, I would request you to add prolactin and procalcitonin to that list, because it tends to happen a lot and the consequences are kind of disastrous. Precious time gets lost. And I think we can think about making this terminology a little more official. Look-alike and sound-alike tests, it can go a long way. So
Yes, I
that's
agree.
from me, sir. That's from me, sir. Thank you so much.
Thank you.
Thank you, Dr. Deepti. Sir, I had one question which has come up. It is like the query is from a small lab. They say that these 16 pre-analytical quality indicators, or the total of 60. So what is the minimum number that a small laboratory can have for each and every quality indicator, and especially since we are talking about the pre-analytical?
So I think there is no minimum number. I am repeating my point that this cannot be one-stop solution for everyone. It will change as per what is the kind of samples that you are getting. How are you? What is the source of your samples? What I mean to say. Say, for example, if I'm talking about a reference lab where you have walk-in patients, where you have home collection samples, where you have lab-to-lab referral samples. These are the three ways that the samples are coming. Then each needs to be understood in a detailed way. In a hospital setup, we need to go, probably ICU collection is something different. Other ward collection is different. My own OPD collection is different. And the process is different there because the users there are different. So I don't think that there is any number which anyone can tell, and there is none which exists. And what I showed as 60 or 16, it was just one paper, which is an IFCCC recommended paper, which I have shared as a document to refer to. I am not trying to propose that you need to have all 16 being implemented in the lab. It is not possible for anyone. And it may not be applicable. When you read that reference document, you yourself probably would understand. What the point is that you need to identify your areas which are problem or bottleneck in your pre-analytical process and take up them as your quality indicators. But if I have to give you a number, ideally what is expected as quality indicators in the lab is that it stretches in all the three zones: pre-analytical, analytical, post-analytical. And if I have to cover pre-analytical zone, then your quality indicator should cover your entire spectrum of your entire process. This is what I am trying to say. The way I showed you, I broke them up into my three main heads as phlebotomy, sample transport, and sample accession. So if these are my three main areas in my pre-analytical zone, then I need to have at least one for each. So I need to have at least three quality indicators in my pre-analytical. That's the logic that I would put in. But this will change as per your lab settings.
I would like to add in the same vein that this is very well put. You've said it so clearly. And you have to go to your procedures, how everything happens at your end in your lab, right from the sample collection to the reporting. As you said, break it up into three areas and see where is the problem in your system, and use that as a quality indicator rather than the areas that are running smoothly. Okay, you don't get a problem in that. It's not much point having that as a quality indicator. Use the one where there is a problem, where you decipher that this is not happening correctly. Let's use it as a quality indicator and see if we can reduce those incidents. So I think that is one other way to approach it.
Thank you, Dr. Bendre. Thank you, Dr. Seema ma'am. Definitely, there is a lot of learning. Also, there is one more question. There's someone who has requested for the LASA slide once again to be shared. Sir, if you could kindly do the needful.
I mean, this exercise is on. I mean, this is based on whatever the issues which cropped up after discussing the team. But I think when you go back and talk to your team, and based on the kind of prescriptions you receive, your team only will give you a lot of inputs.
In fact, we have Dr. Deepthi who's just added one more. And sir, I
Yes,
would strongly request you, sir, that let's take this as one of the new things that we can do it in laboratory medicine, at least in our country. And through Kaho, of course, we can take it ahead and will make a lot of difference to all the participants who are going to attend to this. Thank you.
sure, sure.
Thank you so much. And thank you for arranging these monthly sessions, actually 2 weekly sessions, or weekly is it now? So we are really fortunate to have Dr. Aparna and Dr. Santwana organizing these sessions. And we are also to have such wonderful speakers. Dr. Bendre, thank you so much for being with us today. And most of all, we are fortunate to have all the audience. Without them, none of our sessions would be successful. I hope everyone finds enough of material there to really take forward practically in their labs and in the day-to-day functioning. Thank you very much.